Hi, this is Dr. Mario Del Cid, and this video is intended to describe concepts related to diabetic retinopathy, including disease, imaging, and treatment strategies. Diabetes is an epidemic. Almost 26 million children and adults in the United States are afflicted with the condition. Sadly, almost a third of them don't know they have it. They're undiagnosed. And a whopping 80 million Americans are pre-diabetic. There's two types of diabetes. Type 1 diabetics are associated with decreased insulin production from the pancreas. It's early or juvenile onset. It's insulin dependent because the pancreas isn't producing insulin. Usually afflicts those of younger age, and it's oftentimes treated with insulin replacement and more recently, organ transplantation. It's a relatively small percentage of those with diabetes. Only about 10% of diabetics are type 1. Type 2 is the far more common type of diabetes, is associated with a decreased response to insulin by target tissues. These include the liver, muscles, and adipose or fat. It's adult onset. It's called non-insulin dependent because it's not due to low insulin. In fact, many of these patients have very high insulin. It's simply that tissues don't respond to insulin as they should. Most frequently affects those of middle or working age. Usually requires oral medications and possibly insulin. And it's the far more common type of diabetes. About 90% of diabetics are type 2. It's more likely in those that are obese, have a genetic predisposition, and certain ethnic groups have a higher incidence of type 2 diabetes. The diagnostic criteria, they vary somewhat and they're changed, but in general, fasting sugar of greater than 126 or a random sugar of greater than 200 plus symptoms. Some symptoms of diabetes can include excessive thirst or appetite, increased urination, unusual weight loss or gain, fatigue, nausea or vomiting, blurred vision, dry mouth, and slow healing. Glycolated hemoglobin, or the hemoglobin A1C, is a very important number to know. Although it's not diagnostic, it's a measure of the last 2 or 3 months of blood sugar levels. How does elevated blood sugar lead to pathology? Well, it can affect multiple organs in various different ways, and this is not completely understood. One way it causes issues is by reducing red blood cells' oxygen carrying capacity. Next, it can damage blood vessels in various different ways. It induces microangiopathy, it damages endothelial cells as well as parasites, which are in charge of maintaining blood vessel health. It thickens the basement membrane. It induces permeability, abnormalities. It can cause closure of smaller blood vessels. This can lead to ischemia and ultimately hypoxia. Various organs can be affected, but of course, we're going to focus on the eyes. Diabetic eye disease isn't only retinopathy. Diabetics have a higher incidence of dry eye, corneal epithelial defects, cataract, glaucoma, optic nerve swelling, or ischemia, cranial nerve palsies, and of course, retinopathy. So let's talk a little bit more about retinopathy. It's the leading cause of blindness in those of working age. Between 2005 and 2008, 4 million of those with diabetes, that's almost 30%, age 40 or older, had some degree of retinopathy. Almost 5% of them had advanced disease. Treatment can reduce the risk of vision loss by 50%, and probably more recent evidence shows even greater risk reduction. Duration of diabetes is the most important risk factor in determining whether or not an individual with diabetes may have diabetic retinopathy. If you're type 2 diabetic, At the time of diagnosis, 5% will already have diabetic retinopathy. After 10 years, 30% will, and after 30 years, 50% will. Type 1 diabetics, the evidence is more grim. At time of diagnosis, it's uncommon to have diabetic retinopathy. However, after 10 years, 50% will, and after 30 years, almost all people with type 1 diabetes will have some degree of retinopathy. The pathogenesis of diabetic retinopathy starts with microvascular occlusion. Also recall red blood cells' poor oxygen carrying capacity. This leads to retinal ischemia, retinal hypoxia, which can lead to fibrous glial proliferation, also known as neovascularization, or arteriovenous shunting. There's two forms of diabetic retinopathy, proliferative and non-proliferative, and one major complication which can happen in either case is diabetic macular edema. So let's start with discussing non-proliferative diabetic retinopathy, or NPDR. Those with NPDR usually display microaneurysms, exudates, which are essentially lipid deposits from leakage, retinal hemorrhages, and cotton wool spots. In more advanced cases, one can see evidence of intraretinal microvascular abnormalities, or IRMA. It's not true neovascularization, but it's a sign of advanced disease, as is venous beading, this sausage-like appearance to the retinal veins. Angiography can be useful in patients with NPDR, although it's not absolutely necessary in all cases. It can assist in recognizing areas of leakage to guide therapy. It can demonstrate areas of capillary non-perfusion, and in some circumstances where you may think the patient has NPDR, after angiography you may see areas of neovascularization and the patient may in fact have proliferative disease, or PDR. A few examples. This is an older angiogram. You see these multiple little light bulb-like microaneurysms with very little leakage. Good perfusion here. This is mild NPDR. Here's more advanced case. See more of these light bulb-like microaneurysms with some leakage just temporal to the fovea. This picture shows a blackening of the retina, which is capillary non-perfusion, which is a sign of severe ischemia. And this wide field image shows peripheral capillary non-perfusion. Well, how do we treat it? Well, first you have to address the underlying condition. Address the blood sugar. Strict control can reduce the risk of developing retinopathy by up to 75%. And it can reduce the rate of progression of disease by up to 50%. That's incredible. We have to urge patients to do a better job controlling their blood sugar. In addition, controlling their blood pressure, cholesterol, reducing weight, and monitoring very carefully those that are pregnant are critical in managing patients with non-proliferative disease. Next, let's talk about proliferative diabetic retinopathy, or PDR. In PDR, one will see areas of neovascularization, membranes and scar tissue. In advanced cases, one may see tractional detachments, vitreous hemorrhage, neovascularization of the iris and angle, and neovascular glaucoma. Here's an angiogram of a fairly large fibrovascular frond of neovascularization. A montage image of various foci of neovascularization in the periphery. Wide field image of capillary non-perfusion and multiple fronds of neovascularization elsewhere. And a more subtle wide field image with peripheral capillary non-perfusion and only a few foci of neovascularization elsewhere. Ultrasound may be necessary in those with PDR. If the view to the fundus is obstructed due to dense cataracts or vitreous hemorrhage, for example, in this photograph, there's a vitreous hemorrhage, difficult to see what's going on behind the eye. The middle image is the same patient's ultrasound. Just shows a lot of hyperreflective material within the vitreous cavity, which is hemorrhage. Thankfully, the retina is intact. That bottom ultrasound, the retina is detached due to traction. Visual field testing can be useful. Oftentimes, those with proliferative disease will have some peripheral field constriction. This can be due to dense laser, as this patient's image shows. Peripheral ischemia or capillary non-perfusion can lead to peripheral vision loss as well. And remember, the incidence of glaucoma in those in diabetes can be somewhat higher. This can also lead to peripheral vision loss. Treatment can include laser photocoagulation or PRP. It reduces neovascularization. It can prevent hemorrhage. It can be performed in several sessions and it can be repeated. You can gauge the effectiveness of PRP by noticing involution of areas of NBE, absorption of hemorrhage, and reduction of venous dilation. We'll discuss anti-VEGF further, but this is also a very effective treatment for those with PDR. Vitrectomy or surgery may be necessary in those that have non-clearing vitreous hemorrhage, who develop retinal detachments. Okay, let's talk about probably the most important aspect of managing patients with diabetic retinopathy, and that's addressing diabetic macular edema, or DME. DME may occur in those with PDR or NPDR and is the major vision-threatening complication of diabetes in the eye. Okay? There's two classifications. It can be focal. In focal DME, one can identify clearly identifiable source. It's usually discrete, whereas in diffuse, you can see occult leakage, and it usually involves larger areas, and it tends to be more centrally located. DME is more likely in patients who have PDR or who have poor glycemic and blood pressure control, or those who have significant retinal ischemia. Pathogenesis of DME, initially one gets parasite and endothelial damage, which can then lead to microvascular leakage. This leads to both hemorrhaging as well as edema. Remember, the edema can be both diffuse or localized. This is a picture of more focal macular edema. You see the fovea here is preserved. There's no edema there, or minimal edema. Most of it's off to the temporal area, and it's fairly focal. This other image, you see there's definitely edema within the foveal center, and there's a more diffuse pattern to the edema. OCT on the top shows a large cystic spaces in the outer plexiform layer with exudation, intraretinal exudates. This is a patient with fairly significant diabetic macular edema. After several treatments, patient's macular edema has improved significantly. These are more severe cases of diabetic macular edema. The top pictures show large, very large cystic spaces with subretinal fluid. The bottom picture shows, in addition to macular edema, areas of vitreomacular traction. Treatment for DME, there's various. Laser can certainly be considered. It was considered the standard of care for decades prior to the advent of anti-VEGF therapy. It can reduce the risk of vision loss by 50%. It can be applied directly to microaneurysms or in a grid pattern. It can take a long time to see the effect, and it can be more effective in those with very focal, non-foveal involving DME. Downside of laser is it leaves a scar, and one can develop paracentral scotomas in areas of scarring. Anti-VEGF has become the mainstay of therapy for those with DME. One could also consider other treatments, including steroids or surgery. So what is VEGF? vascular endothelial growth factor. It's a key molecule involved in vasculogenesis, or blood vessel formation, and vascular function. It's released by endothelial cells, retinal pigment epithelial cells, as well as other glial cells in the retina in response to hypoxia. Its effects are in the production of new blood vessels, that is neovascularization, and increased vascular permeability, which leads to macular edema. So, VEGF. How does this happen? Well, you get microvascular occlusion, you get hypoxia or retinal ischemia. This leads to the release of VEGF. VEGF can lead to neovascularization, otherwise known as proliferative diabetic retinopathy or PDR. It can also lead to capillary leakage, which is known as DME. Anti-VEGF agents, there's various. These include bevacizumab, ranibizumab, aflibercept. DRCR-NET, which is a large group, has done lots of studies on the use of these agents in treating those with DME, as well as those treating those with PDR and NPDR. Lots of other studies, including pharmaceutical-sponsored studies and many others. The evidence is very clear. These agents work, and they work well. Other options include steroids. Steroids work by decreasing the vascular permeability. They help to stabilize the blood-retina barrier and decrease VEGF expression. The downside of steroids is they have slightly more side effects, including glaucoma and cataract, but they still may be used in certain circumstances, and some examples include Ozurdex, Iluvien, Triamcinolone. Surgery, that is vitrectomy, can be considered to increase oxygenation, and membrane peeling can be considered in those with traction. Oftentimes, diabetics require a combined approach. Some general principles. These are rules of thumb. They're not laws. Laser, usually considered in those with very focal macular edema, those that are intolerant of intravitreal injections, and usually in those where the edema is not involving the fovea. Anti-VEGF therapy is probably the more commonly utilized treatment option. It works well in those with any kind of macular edema, but especially in those that have diffuse edema involving the fovea and where there's subretinal fluid. Steroids can be utilized in those that don't respond to either one of the above treatment options, or as a primary therapy. Usually you want to treat, if you can, those that have already had cataract surgery, and certainly those that don't have advanced glaucoma. Vitrectomy can be considered in non-responders, in those that have traction, or if there's a need to do vitrectomy for other conditions such as proliferative disease or vitreous hemorrhage. So here's a few examples. This is a 48-year-old male with non-insulin dependent, that is type 2 diabetes. He had recent cataract surgery complicated by vitreous hemorrhage and hyphema. He was observed initially for several months. As the hemorrhage cleared, one could get a better view into the fundus, and this is what we had. Fairly dense and pronounced fibrovascular tissue on the right eye. The left eye looks like there's non-proliferative disease, few dot blot hemorrhages, and so on. The fluorescein angiogram on the left eye shows some neovascularization elsewhere. The right eye, again, highlights that dense fibrovascular tissue. This patient underwent vitrectomy on the right eye and panretinal photocoagulation on the left eye. Post-op appearance, the anatomy was restored, the vision improved, and patient's doing quite well. This is a 67-year-old female with type 2 diabetes, noted some blurred vision on the left eye. She's pseudophakic in that left eye, and when you look back there, you see the right eye, the view is not so clear due to the cataract. The OCT on the right eye looks normal. However, the left eye, you see this small areas of exudation just infratemporal to the fovea, some dot blot hemorrhages in the periphery. The OCT clearly shows that This is a area of leakage just infratemporal to the fovea. It's small, it's discrete, it's focal, it does not involve the fovea. So we decided to do focal laser. And after one treatment of focal laser, you can see there the laser marks, swelling went away. Patient's really happy. This is a 59-year-old male with type 2 diabetes, history of multiple procedures in the past, now with some vision loss on the right eye, has a mild cataract. Fundus exam shows some of the laser marks on the angiogram, some leakage, lots of dot blot hemorrhages and microaneurysms, but the OCT is really telling. Large pockets of cystoid macular edema with some subretinal fluid. So he underwent an injection of ranibizumab. 4 weeks later, looks fantastic. Vision's down back to 20/25. Patient's very happy. So we decided to not do any more treatments. Decided to follow him up in a couple of months. I think he missed an appointment. Comes back now with a recurrence. This is very typical. Additional injection performed and follow-up 4 weeks later. We're back to 2025. So this patient obviously is going to need careful monitoring and likely additional injections. So in conclusion, diabetes is on the rise. Most, if not all, of the ocular complications are preventable or at the very least treatable. Lots of new treatments are emerging, and your role in this whole process is critical. Thanks so much.